1, go.
Hello, Bellingham Fire Department. For quarter 4 education, I wanted to do a small module on physical exam skills. So generally, I think we feel that ALS kind of owns the physical exam, but there's no reason for that. That's not true. I think BLS with proper education can do a physical exam just as well as ALS. So I wanted to go over a couple of physical exam maneuvers, and I've asked Captain Frank to be our model today and assist me with this. So thank you. The two exams that I think are really important based on what I've seen in people's documentation to reinforce are the trauma exam and the neuro exam. But wanted to go over a couple of other exam maneuvers beforehand. So first of all, every exam that you do answers a clinical question that you're asking. So for instance, let's start with the cardiac exam. So there's not that much that I think pre-hospital providers are going to derive from a cardiac exam other than, does the patient have a murmur, and is the heart muffled such that you're suspecting fluid around the heart? So let's start with the murmur. If you listen over the heart and you hear a murmur, that is more likely baseline for that patient. But the reason that you're listening is if that patient spontaneously ruptured their valve and have a new murmur and they look sick, so they're hypotensive, they're tachycardic, they're sweating, they're got poor skin signs and cap refill, that's an important thing to know on your physical exam. For muffled heart tones, you're thinking, especially in a trauma patient, do they have blood collecting around their heart? Or in a patient with rheumatologic disease or some other reason that they would have fluid around their heart, is there fluid collecting that's tamponading off the heart? So you would take a stethoscope, which should be in every kit, put it in, and you are just listening right there, which should be about the 4th intercostal space, just left of the sternum, and that should be able to answer those two questions of, are there muffled heart tones, and do you hear a murmur? Lungs. So for the lung exam, you're really only going to be answering a couple of questions. So in trauma, you're listening to say, are there bilateral breath sounds? And you're assessing for pneumothorax. Be alert that if someone has a pneumothorax, the air is going to float to the highest position. So if they are lying flat, if they're lying supine, that air is going to be up at the top. And anywhere that you listen on the anterior lung fields, you may hear decreased breath sounds on one side, but you might not. If it's a small pneumothorax, they might sound equal. So just be aware that when you're listening for breath sounds, it's not completely sensitive. If they're sitting upright and you're listening for a pneumothorax, you're going to hear it best if you listen at the very top. So for pneumothorax, you want to listen either to the front or to the very top on the back on both sides to listen for equal breath sounds. For the other couple things that you would be listening for as pre-hospital providers on your lung exam are, is this asthma or COPD? So you're listening for wheezing. The other circumstance that you might hear that is an allergic reaction and an anaphylaxis. Sometimes they can have wheezing or other causes of pulmonary edema. In general, if it's asthma or COPD, you're going to hear that best at the top of the lungs. And there's inspiratory and expiratory wheezing. So, and then it's kind of hard to simulate, but at the very end of the expiration would be the most sensitive for asthma or COPD. So in general, again, you're listening at the top of the anterior lungs and the top of the posterior lungs, and you're listening for wheezing. That might also sound like stridor. So if you're hearing it on the inspiratory phase, if someone is having stridor from their neck, it'll go, and you might hear that transmitted into the lung sound. So just be aware that that's sort of a confounding sound. Other things that you're going to be listening for on your lung exam. So if you're worried that someone has pulmonary edema or that they have CHF with edema due to that, you're going to hear crackles at the lung bases. And usually you're going to hear those best at the lower posterior lung field. So lower on the right, lower on the left. And if you hear that, then at least it gives you a sign that that person has potentially has fluid accumulation. If you hear it only on one side versus another, that can also be pneumonia. It could be that you have a slight asymmetry of the fluid collection because it's early on. It also could be that that person has a pleural effusion that's accumulating on one side, so you're really only hearing it on the other side more pronounced. All right. going on to the abdominal exam. I'm going to have Joe lay down. Thank you, Joe. There's not that much that you're looking for on the abdominal exam. So one big thing would be distension. So if you're worried that someone has a bowel obstruction, or let's say it's a trauma patient and they've perforated their bowel, So you're really just looking at the abdomen and seeing if it looks kind of poofed up. Yes, this is hard to decipher in most of our patients since many people are somewhat obese, but you're looking to see, does it look sort of distended or ballooned up? The other thing that I want you to look for is tenderness, and just remember the difference between tenderness and pain. So tenderness is when I push on his abdomen and he shows me signs that he's in pain. Pain is just when I say, hey Joe, does your abdomen hurt? And he says yes.
Yes.
But
ouch.
There you go, ouch. When I'm feeling for tenderness, I don't even ask the patient, does this hurt? Because people will often say yes. Tenderness is that they're showing me. So I'm pushing on his belly in all 4 quadrants, right upper, left lower, right lower, and I'm looking at his face to see if he winces. Because if someone has appendicitis or they have diverticulitis or something else that's very painful and you push on it, they're going to show you with their facial expression that it really hurts if they're a fully alert patient. All right, I will have you sit back up. Thank you. All right, let's go on to the neuro exam. So very, very frequently I'm reviewing charts and I see that someone has a seizure or they have a query for stroke or some other neurologic complaint and there is no neuro exam filled out, or a very, very brief neuro exam that might just include GCS. So remember that a full neuro exam includes 5 different things, at least that I would assess in the ER. And it might not be necessary for you to assess all of these things because it's not going to make a difference of what you do pre-hospitally. But those 5 things are cranial nerves, so assessing facial function, speech, shoulder shrug, vision, things like that. The mental status of the patient. Motor, so how good is their strength and their movement. Their sensation, that's number 4, and then balance and gait, and that tests the vestibular system. There's a lot that you can tell on the neuro exam just by looking at the patient, and I document this a ton when I see a patient in the ER, and it doesn't require me to do any exam maneuvers, it's just information that I gather while doing the history. So some of those things would be, are they speaking with clear speech? Are they providing the history themselves, and do they have normal thought content with that? Are they answering questions appropriately? Are they attentive to your conversation, or do they keep getting distracted and do you have to keep asking them to answer your questions and return to the conversation? With spontaneous movements that most patients are making throughout your history, do they appear to have full strength, range of motion, and coordination? And then you looking at their eyes, seeing if they have full extraocular movements, their facial movements, are they having any obvious asymmetry when they move their face? And then oftentimes you'll get some assessment of a patient's gait or coordination just as they're maybe walking around their house or walking out to meet you. Just a brief comment about seizures. So a lot of times I see people say that someone did or did not have seizure activity, or that they actually witnessed it but they won't give a description. So just remember there's lots of types of seizures. So there's generalized tonic-clonic seizures, which is what we generally refer to as a seizure, and that would be the entire brain affected by the seizure, and you'll see this is called clonic when you're going back and forth, and tonic means that you're flexing your muscles. So the whole body, usually the arms and legs, are stiff and having some sort of repetitive movement. So I would love it if you guys in your reports would say that you witnessed or you did not witness, or in what extremity you witnessed generalized tonic-clonic movements if you're describing that. You can also have a partial seizure, so if that's only affecting part of the brain, it might be only affecting one extremity, but not all 4, and the patient can have a normal level of consciousness, be able to converse and answer questions throughout that. And these descriptions are really, really helpful to the ER doctors and to the neurologists when trying to figure out after the fact what happened, was it actually a seizure, and what type of seizure. So your description in your report is really important for this. And then there's other types of seizures. There's absence seizures, where they sort of stare off into space or just kind of are confused or not responsive for a short period of time. So just remember, when you're seeing a seizure patient, describe what you're seeing, and you can put that in, next to your exam section when you're assessing their neurologic exam. Okay. Let's talk briefly about a coma exam. So let's say you see a patient that has a very decreased level of consciousness. You can still do a neurologic exam in these patients. So you might not be assessing their strength or sensation the way that you could in a normally alert patient, but if someone is completely obtunded, you can, actually I'm going to have you lay back down again, thank you. Up, down, up, down. So Joe is comatose, perhaps he's overdosed on an opiate, or perhaps he has meningitis, or he had a head injury, or something like that. I'm trying to assess, does he have any neurologic function? So one thing I would do is he going to react to painful stimuli? And you can do this, I'm not going to do really painful stimuli on you. So there's sternal rubbing, where you put your knuckles on their sternum and kind of rub. Some people suggest against this because you can leave bruising, and that is troublesome to the patient and the family later when they say, what did you do to me? But if you rub on their sternum, maybe through a layer of clothing, in general, you can do this to yourself, it hurts. And they will hopefully react to that and try to reach up and grab your hand and pull it away. And then you can say, did they have any motor function in response to that? Do they have decorticate or decerebrate posturing in response to your painful stimuli? Or did they actually have purposeful movement where they reached up and they grabbed you, or they pulled you away, or they crossed the midline? And that's important to know. Other painful stimuli you can do, so you can go right behind the ears and sort of like just push there and apply pressure. That tends to be pretty painful. You can grab their clavicles and sort of pinch right there, and that can be painful. And then what I usually do is I take a pen or something, and on all four of their extremities I will push it, I'm going to pretend this is a pen, I will push it against the nail bed and just push right there. And most people, oh, you have a pen, thank you. Just push, like that, and most people will react against that, and I will do that on all four extremities, and it tells me that the nerves in the arm, the spinal cord, and the brain are working well enough in that patient that I think might be comatose. Then I will also assess their pupils. You guys should know this, but if you take a bright light and you shine it into their eyes, you're seeing if they have pupillary reaction. And then you can do corneal reflex. So corneal reflex technically would be touching or blowing air on the cornea and seeing if they close their eyes in response to that. What I usually do is just touch their eyelashes, and if I touch his eyelashes, he blinks. So he has an intact brainstem. That's great. Yeah. And then you can also do gag reflex. Just be aware that if you do gag reflex on someone where it is intact, which hopefully it is, they might vomit on you, and we don't want to cause aspiration, so either don't do that or just sort of be gentle and be careful when you're doing that. But so these things are pupils, gag reflex, corneal reflex, and then assessing painful stimuli either centrally to see if they cross midline and have purposeful movement, or in all four extremities to see what someone's baseline neurologic status is in someone that has a very decreased level of consciousness.
What do you suggest for testing the gag reflex?
So Joe asked, what do I suggest for testing the gag reflex? So I would say either if you're putting in an oral airway, sometimes that kind of creates a gag reflex. Like if you've ever put one in your mouth, like it goes fairly far back down your tongue, and people don't like that, and they sort of do that to get it out. So either putting in an OPA might sort of assess it well enough, or I take a tongue depressor. We don't have tongue depressors, right? We have tongue depressors. Do a tongue depressor and just cram it towards the back of their mouth and see if they do something in response to it. All right. And then just a really quick neuro exam. So the neuro exam that I do in the ER, I'm not expecting you guys to do this entire thing, but let me have you sit up again. Thanks. This is an exercise in sitting up and laying down. I'm going to ask you to briefly take off your hat. Thank you. Okay, so this is the neuro exam that I do in patients in the ER where I want to do sort of a thorough neurologic exam, and then I add things on or off of that based on what exactly I'm assessing and what question I'm trying to answer. So first, I'm going to touch your face, and does that feel normal?
Yes.
And I do it in 3 areas, the top, the middle, and the bottom, because there's 3 nerves that supply the different areas of your face. Then I touch your hands, does that feel normal? Touch your legs, does that feel normal? So now I've assessed sensation in all extremities and all areas of the face. So that's sensory. Motor. Well, I'm going to go back to cranial nerves. So first I say close your eyes real tight, good, you can relax, and then smile, good. So now just there you've assessed whether they've got full facial strength and no droop or asymmetry with that. And then I say look at my finger, watch it go across. There we go, so his extraocular movements are intact. I'm looking at his pupils and seeing if they look grossly symmetric. And then open your mouth, say ah. Great, and when you look at the back of their mouth, you should see the uvula, which is the little thing that comes down in the middle. That should elevate, and if you see that, you're already assessing 2 cranial nerves with that. And that they can open their mouth and they don't have any asymmetry with that. So I do those things to assess the face, and then grab my hands, pull me towards you. He's very strong. Push me away. Good strength. And then kick out against me. Kick out against me here. Pull back, and then feet up, feet down. Good. So now I've assessed that he's got good strength in all extremities. Very strong, Joe. And from that, you can also do balance. So if you were assessing balance, I would ask Joe to stand up and take a step away from the table a little bit, put your feet together, close your eyes. Okay, so if he can do this, hey, eyes closed, thank you. So if he can do that and not fall over or drift to one side, that already assesses his balance pretty well. The other thing you can do is just have them casually walk. You can open your eyes, thank you. So if you just have them casually walk to the stretcher or across the room, that can assess gait, and that's probably good enough for what we need to do in the pre-hospital environment. All right, I'll have you sit back down. The other thing, just to quickly teach so that you know what it is this maneuver called finger, nose, finger, and we do this to assess balance or ataxia. You're assessing essentially how well their coordination works in a patient that you don't want to be getting up to stand or walk, maybe a trauma patient or a patient that has a hip fracture or an amputation or something like that. So I would hold my finger out and I'd say, Joe, touch my fingertip with your fingertip, and now touch your nose, and now go back and forth as fast as you can. Good. And do it with the other finger. Good. Thank you. And what you're looking for is accuracy. So he should be touching my fingertip exactly on the tip, and then when he touches his nose, is exactly on the tip. You can relax. So what some people who don't have this will do is that when they reach out to touch the fingertip, they sort of do this and search through the air, and then they'll get it, and then they'll go back and they'll kind of do that, and then they'll get it. And they might touch their nose on the side, they might touch your finger on the side, so you're looking for precision and accuracy. Are they exactly on the tip of your finger? Or are they exactly on the tip of your nose? And that assesses for something called ataxia, which is a loss of coordination. And you can do that. So that's essentially like testing balance, but with them sitting back down. You can put your hat back on. You're welcome. All right, moving on from the neurologic exam, I want to talk about trauma exam. So you guys should know from your initial trauma training that when we initially see a potentially sick trauma patient, you want to be doing ABCs initially. So I'm looking at their face, looking for signs of facial trauma, and I will just ask them a question like, what happened, or are you in pain, or how are you, what's your name, and if they answer with normal speech, like boom, their airway is intact enough to talk, to breathe, and to speak clearly. If not, you might be looking for obstructions, for teeth that are dislodged, a lot of bleeding in their mouth, just by asking them to open their mouth. Breathing, we already talked about this a little bit, but you're mostly just listening for equal breath sounds. And then circulation, so a lot of breathing and circulation, at least the physical exam, is just getting vital signs. Are they hypotensive? Are they tachycardic? What's their respiratory rate? Are they hypoxic? But with circulation, you can also look for a pulse in all 4 extremities, especially if they have signs of significant extremity trauma. And you can look for capillary refill and for signs of good peripheral circulation. All right, moving on from the ABCs. So the next thing is exposure. So just, you guys know this, I know, but you're trying to take all of the clothes off of the patient in a respectful way that is keeping them warm, but at least looking to make sure that you're not missing injury. So looking for lacerations, let's say it's a gunshot wound or a stab wound, really looking at all of their skin, including all of the back and the buttocks, making sure that you're not missing an exit wound or an additional stab wound. And then looking for deformities, especially in extremities, for a potential fracture or something that you could splint to help reduce further injury or pain. All right, going on to the spine. So if it's a significant trauma, you probably want to be rolling the patient, or you don't want them to be moving very much, at least until you assess their spine. So I think everyone can do this, ALS and BLS, but what you want to do is with them laying supine. I'll have you lay flat, please. Thank you. So I don't want him to move, so you try to get the patient, into, this position, especially since you're going to try to transport them like this probably. And then I will say, please don't move your neck if it's a conscious patient, or I will put my finger on their forehead, because that is a good reminder, because everyone, once you start palping their neck, they try to lift their head to help you out with the exam, but you don't want them to do that. So I'll put my finger on their forehead, and I'll just reach back and palpate from C1 in the midline all the way down to C7. And again, I'm looking at their face to see if they wince, to say that they're tender in those spots. And if they are, you shouldn't be doing anything more. You should just be putting on a C-collar or putting blocks, but making sure that you're getting good cervical immobilization. Remember as well that you can have unstable fractures in the thoracic or the lumbar region, so you don't need to roll every patient to assess for that, especially if they're going to the ER, and we're going to be doing that at the ER anyways. But if you are, considering sitting up the patient or allowing them to move more freely, just make sure that you've assessed their thoracic and lumbar spine, and make sure that they don't have a tender area that might indicate that they have a burst fracture or an unstable fracture at that location. Pelvic compression. So for any major trauma, this is really important, because you're determining if you want to be putting on a pelvic binder. If they're showing signs of shock, so they're hypotensive or they're really tachycardic, that patient, if they have a mechanism that fits with a potential pelvic fracture, should be getting a pelvic binder no matter what. But if you want to assess to see if you think that they have a pelvic fracture, the way that you do this is you got this big belt on, but you find their anterior iliac spine, so that's like your hip bone right in front right there. You put your thumb there, and then your fingers on the back of the pelvis there. Do it on both sides, and then you're pushing together. So you're compressing that way. If you do this and you feel any movement, do not let go. So you push, you go, oop, I felt movement. You hold it there and do not release until someone can get a pelvic binder or a tight-fitting sheet, a second person can wrap it around and secure it, and then you let go. Because the more that, let's say you compress and you feel a little bit of give and you let go, every time that we do that, either someone's doing it during exam or during the placement of the pelvic binder, you're disrupting the fracture. You are potentially lacerating more arteries or veins and causing more bleeding. So we just want to do it once, do it really well, and then determine if you need to put on a pelvic binder if that patient has stable vital signs otherwise. I see some people sort of rocking the pelvis or pushing down. We're only doing this maneuver to assess for an open book fracture, meaning that the pubic symphysis in the front is fractured, or the bones in the front, and the pelvis has splayed open. We're not looking for other pelvic fractures, because putting on a pelvic binder isn't going to help those other types of pelvic fractures. It really only helps an open book fracture. Okay. Abdomen, so if someone is a trauma patient, you just want to do the same thing, push on all 4 quadrants and see if they're tender in those spots. And then moving on to extremities. So you want to make sure that you're assessing the bones, and then their strength and sensation, and then whether their blood vessels are working. So assessing, you can just look at the patient. If they look like they're having, like they had any extremity trauma, then you need to make sure that you're doing strength and sensation in the hands or the feet and assessing the pulse. But if they obviously don't have any extremity trauma, it's not so important to do a really detailed exam of the hands and feet. But what I usually do is if they have intact mental status, I'll say, make a fist, wrists up and down, elbows in and out, arms up. Good. Okay, you can relax. So in doing that, he's told me that all of his joints have good strength, have good range of motion, and that at least his nerves are working well enough to do, that full maneuver. And then I'll say, one leg all the way in and out, and the other leg all the way in and out. Good. So again, that tells me very quickly that he has, no extremity. You're not going to do that if you have a major fracture, and if your nerves aren't working or your blood vessels aren't working, you're not going to be able to do those maneuvers. Let's say Joe has had significant trauma and is really not alert enough to do something like that, then just put your hands down by your side. I'll just make sure that I palpate essentially all of his extremities. So just start, go down, and then here, go down. And you're just feeling for deformities, and then again, I'm looking at his face while I do that and looking for him to wince in pain. And then the last part of sort of the trauma exam I want to make sure you guys are doing is just mental status and GCS, and monitoring that as a vital sign, hopefully at least every 5 to 15 minutes during your transport. And you guys know how to do GCS, but just make sure that you're assessing that and then asking questions to assess mental status. So, okay, you can sit up. All right, so that's just a really brief thing, but just wanted to go over especially the neuro exam and the trauma exam, and then just a couple of physical exam maneuvers. Again, remember that documentation of this is really important. I'm looking for this when I review your charts. If you ever had a case that was came up for a legal case, these sort of things will be reviewed. And then, doctors are using your charts down the road if they need to, especially for like a seizure patient, as we talked about, look back and see what you witnessed and what your exam of the patient was. So if you have any questions, I'm around. Please come find me, and thanks so much.
Wait, how's my makeup?
Oh, it's good. It's coming off real good. You don't look that pale.
You smell wrong?
How
about when it's like...
Sure, I know what I'm going to say.
You can hand her like a cardboard cutout and hold up like you're doing the real stuff?
Yeah. Okay.
Trying to catch your mouth breathing on there?
Linda, tell me when we're going.
Oh, I've been going this whole time.
Oh, yes.
This is gonna be hard. Okay. And I'm kissing.
How's my posture?
No, it's good.
Okay, why don't you give me like a 3, 2, 1, and I'll
Okay.
just start, and I might need to do it again, and that's gonna be okay.
Is it?
Yeah, it is.
And 3,
Okay.
2, 1, go.
Is it been on the entire time?
Yes.
Oh.
Yes.
I wasn't sure when you cut it, and then.
Yeah, I was gonna edit this all out.
But
Yeah.
no, she's not. She's going to use some of it strategically against us. No.
Serious faces?
You can't say that and expect me not to laugh. My nose hair's good? How about my eyebrow?
Yeah.
You can't notice it from here, you're fine. This is gonna be a real call though soon.
Okay.
What do I look at? Do I look at you while you're talking? Like closely? Just
No. Alright,
breathe on
we're
your shoulder?
wasting Krista's time, so.
Are we?
Yeah.
This is my highlight every day.
Yeah, this is fine.
Wait,
Ready?
no? What am I don't even know what to look at. I'm just going to look at the doorknob.
Serious faces. Okay, I'm gonna start.
You can't say serious.
1, go.
Hello, Bellingham Fire Department for quarter floor. Okay, we're stopping.
Okay, I got it out. I just had to get that one out. I'm only good from here. I was looking at that goddamn photo and I saw Krista's face and I just couldn't.
So we've determined that you should not look at Krista.
Sweaty again.
You're moist.
Yes, oh gosh.
Moist.
Good. Are we ready to do a countdown again?
I don't know.
We might need to do multiple runs because I haven't really.
Hold on. Don't start yet. Can we redo it from the top?